Just want to kick off by thanking you all for joining us for this installment of the Broad Global Health Initiative, looking at the global health impact of the COVID-19 crisis. As I'm sure you know, COVID-19 has surged in South America in recent weeks, leading the WHO to declare it as the new global epicenter of the pandemic. And much like in the US, COVID has also painfully highlighted the significant social and political complexities that are exacerbating the problem. So given our many connections to Latin America, both in terms of our work at the Broad and Broadies themselves, and to the many close connections we have in the community to the region, it's really an important time to hear firsthand about what's happening there. So speaking of the close connections that we have, I'm going to hand over to my colleague and co-host here, Rafael Sanchez, to welcome you on behalf of the Latinx community at the Broad.
Thank you, Bronwyn. Good afternoon, everyone. My name is Rafael Sanchez. Latinx at Broad is a subgroup of the Shades at Broad affinity group at the Broad Institute. The mission of Shades at Broad is to advocate for and support the recruitment, development, and success of ethnic minorities at the Broad. Sharing this mission, Latinx at Broad seeks to build community among Latinx employees and affiliates, promote our rich cultures, and provide education on research done by Latinx scientists or impacting the Latinx community. If we could go to the next slide, please. So worldwide, Brazil follows the US as a country with the most confirmed cases of COVID-19. Within South America, the number of confirmed cases in Brazil is followed by Colombia, with both countries having an upward trend of daily cases. As the pandemic is becoming more controlled in many parts of the world, Latin American country outbreaks are spiking with little to no media coverage or government support. According to an article in the New York Times, in Latin America, the pandemic has been worsened by underfunded hospitals, lean support systems, and struggling economies with far fewer resources than in Europe or the United States. I'm originally from Venezuela, and many of my Latinx at Broad colleagues and their families also call a Latin American country their home. We are very excited to join forces with the Global Health Initiative on today's Coffee Talk, and we look forward to learning perspectives on the COVID-19 crisis in Brazil and Colombia from our guest specialists.
Great, thank you. So just before we hand over to our wonderful panelists that we have this afternoon, I just wanted to take a quick moment to orient any of you who aren't quite familiar with the geography of the region, just a bird's eye view of South America to bring to your attention where Colombia and Brazil sit on the continent. So Colombia is in the northwest kind of corner of South America, and is bordered, shares a significant land border with Venezuela, which I think factors significantly into the COVID crisis there, and also shares a border with Brazil through the Amazon region, which I know is another significant part of the story in both Brazil and Colombia. So with that, it's just a great pleasure to welcome our speakers. They are friends and collaborators of the Global Health Initiative and the Infectious Disease and Microbiome Program at the Broad. Dr. Fernando Bozza is a clinical critical care doctor and research scientist based at the Cruz Institute in Rio, with a long history of working on multiple infectious diseases in the country. Dr. Marcia Castro is based in Boston, just across the river from the Broad, at the Harvard School of Public Health, where she does tremendous work on malaria, looking at the epidemiology and demographics, and was also deeply involved in the Zika epidemic that was centered in Brazil a few years ago, and is of course a Brazilian national herself and continues to work closely in the country. And then moving over to Colombia, we're so proud to welcome Dr. Socrates Herrera, who's a world-renowned malariologist and leads his own institute in Cali, historically focused on malaria, but as many research institutes have, including the Broad, has really pivoted a lot of attention to supporting the COVID response in his country. So without further ado, we're going to hand over now to the speakers to tell you more about their work and their experience and what they're seeing really on the ground in their home countries, and what we can learn from their insights about the work happening in Brazil and Colombia and how it relates to things we're facing at home in the US. So let's hand over to Fernando first here. Oh, just a few quick notes actually before we move on, just to mention that the session is being recorded. Please submit any questions. We hope to have some time for a great Q&A session with the audience. We'd love to see your questions come in real time so we can queue them up. And if your question is selected, we are going to try our best to find you and unmute you so that you can ask your questions directly to the speakers. So just look out for that. If you've asked a question, we'll try our best to make that work. Fernando, let's head over to you. And if you are, let me see, where's the stop share? There we go. If you're happy to take it away.
Okay. Thank you. It's really a great pleasure to take part of this panel, and especially to talk about some data that usually we're not looking. And I prepare some slides just to introduce the subject, and I use this idea of invisible outbreak, and especially to explore what this common data are not showing about the inequity in Brazilian COVID-19 response. And usually, I'm sure all are looking this kind of data coming, for example, from our world in data, where we have this cumulative confirmed cases from US, from Brazil, from European countries, and also deaths and coming from the same place. However, probably this data not express completely all the complexity of this outbreak, and especially the pandemic, especially for some vulnerable populations. And when I picked some special key events that occurred in Brazil after the beginning of pandemic, and we can first identify early response coming from some states really early at the beginning of the outbreak, but after, especially from the central government, we identify really a misconduction of the outbreak. And after 2 months, the president fired the Minister of Health and invite a second Minister of Health that resigned less than 1 month. And now we are starting to open or reopen, for example, malls in Rio and São Paulo, the major cities, still with a large outbreak ongoing. And for other side, we have several differences when we look distribution and lethality around the country. And we can see in this map, for example, the north part of the country. This is the Amazonic area of Brazil with many confirmed cases and also a lot of deaths. And recently, in a national seroprevalence study, we can identify from the 10 higher seroprevalence in 90 cities around the country, 9 cities are in the north part of the country. And this is a little bit small view about the Amazonic situation, and we can identify many cases, and that's close to the rivers, close to the Amazon River. This is the imaging of new cemeteries in Manaus, and also this kind of collective funerals occurring. But one important point is that much of the transportation in this region is done by boat. And this is the view of a boat that usually takes 1 day or 2 days around to go from Manaus, for example, to other cities in close or still in the state of Amazonas or Pará. But and this is in the other map. What I'm showing is in red the access to beds, especially to ICU beds. In red is regions without ICU beds, and this is a little bit of this view about the Amazon. But also, what is really a major issue is that this outbreak is arriving far, even in the forest for isolated populations, and very complex communication and how to manage this outbreak in this population, especially in a moment where we have invasion in areas. For example, the Yanomami area is invaded with more than 20,000 garimpeiros that are using this momentum that where the native population is inside the forest to occupy this territory. Other aspect is how are the socioeconomic determinants of lethality also in the country. We look at a large data bank of Brazilian influenza surveillance with a final sample of more than 54,000 cases of COVID-19. And we identify clearly using multivariable analysis, even with adjustment for race, educational level, region, age, gender, and comorbidities, that this increase lethality, especially in mixed and Black population, in people, especially the illiterate and elementary school population, and also especially in the north and northeast part of the country. Also, this is an applet that our group developed to test, track, and trace, like other initiatives around the world. And we are testing people in Rio de Janeiro. And for example, when we look, this is the symptoms in Rio area, we can see that in rich area, it's green, very low risk. And in red is the periphery of the city with a lot of symptomatic people. And also when we compare the seroprevalence inside the same city, we have people in the more rich area with 5% of seroprevalence, and in some favelas, for example, 35% of seroprevalence. This is a brief introduction and to start this conversation. Thank you.
Thanks, Fernando. Yeah, that's a perfect way to kick off. And let's hand over to Dr. Marcia Castro for further perspective from Brazil, from her work and experience there.
Thank you so much. Thanks for organizing this discussion. I think we need more events when we talk about other places other than the US. So pleasure to be part of this panel. So I'm not going to use slides. I'm going to try to give you a very brief, condensed overview of different issues. Some overlap with what Fernando just said, but the first thing I want to say is that Brazil could have provided a lesson to the world on how to respond to a pandemic using its universal health system and one of the largest networks of community-based primary care in the world. It could have learned from the mistakes and successes from other countries. It had the time for that. And above all, it could have built on its own history of responding to new health threats like Zika and HIV/AIDS. However, what we see is very different, as Fernando showed. So let me raise two issues that contribute to the current scenario we see in Brazil. So first of all, Brazil has a leadership that downplayed the importance of the virus, is against any form of social distancing on the grounds of preventing economic loss, ignores scientific evidence. So this brings challenges to mayors and governors who try to adopt responses that are not really favored by the leadership, by the president, and suffer pressure from business groups that are concerned with financial losses. It also makes it almost impossible to achieve full compliance of the population to those measures as supporters of the president concur with his message. In the absence of strong leadership, we see many local responses given by combinations of public-private partnerships, community groups, NGOs, and government pairing with community organizations. Those responses come in the form of provision of food, protective equipment, healthcare to poor communities, and repurposing industry to produce needed equipment, such as ventilators. The second thing is that by not leveraging its health system, the country failed to guide local health officials on how to engage community health workers to conduct active search of vulnerable individuals, for example, and above all, to perform contact tracing. Most importantly, it failed to provide a locally adapted response, one that addresses inequalities, which are extremely high in Brazil. It's impossible to imagine that, for example, social distancing strategies that, just like the way they worked in Europe, that they're going to work in Brazil without being locally adapted to levels of informal labor, poor housing, no access to water, or low supply of physicians and hospital beds in some localities. In the middle of a pandemic, one would expect that the Ministry of Health would be one of the most important governmental institutions in the country. Yet, as Fernando just mentioned, in less than a month, one minister was fired, another one resigned, and after more than a month since that happened, the Ministry of Health remains ministerless. It has been led by an interim minister, an army general who may know a lot about logistics but knows nothing about health. The consequences of this chaos are reflected in COVID statistics. Brazil is now second country in cases and deaths in the world. It's a matter of days. We're going to hit 1 million cases. We're almost there. I think we are at 955,000 or so. And truth be told, Brazil is the main reason why Latin America is now the epicenter of the pandemic. The statistics expose the inequalities in the country. The majority of cities with highest COVID-related incidence and mortality rates are in the Amazon region, as you saw in the maps that Fernando showed. And many face a shortage of hospital beds and ICU beds. If you look at standardized mortality rates, they are proportionally higher among vulnerable groups living in areas with precarious infrastructure. Managing COVID-19 will be a long-term process, and it demands an alignment between the president, the Ministry of Health, and local leaders around a uniform and scientifically based message. Failed to do so, and I would argue we still have time for that, but we can discuss that later, will put Brazil on a path that results in the unnecessary loss of many lives and the exacerbation of already large social, economic, and regional inequalities.
Thanks, Marcia. Yeah, that together those give a really a great insight into just the sheer complexity of the issues facing Brazil now, and so many elements that you touched on, I think, resonate with the experience in the U.S., which I'd love to come back to, although clearly there's some unique challenges in the Brazilian context. But let's move on and hear from Dr. Socrates Herrera, first for perspective from Colombia, and then we'll open it up to a few questions. Thank you.
Thank you very much, Bronwyn. It is a pleasure to be with you here and with the audience. I think it was a good introduction to have the situation of Brazil in front. And what I want to share with you is what we have been dealing with for the last 3 months here in Colombia. The first few cases were reported by mid-March. And immediately after, the government, both the regional and the local, the national government, decided to close up the country and to subject the entire population to quarantine. And here is what we have 3 months later. As you could see here, and already Bronwyn mentioned, Colombia is located in the corner of South America, connected with Panama and therefore to Central America, with a long border with Venezuela, but no less important with Brazil, Peru, and Ecuador. You can see here from the map, the highest number of cases have occurred in Bogota. Colombia is a country with a population of 45 to 50 million inhabitants, and Bogota is between 8 and 10 million inhabitants. Border with Venezuela, border with Brazil, Peru, and Ecuador. The first few cases were reported 3 months ago in neighborhood of Cali. I am located in Cali. Cali is here. I don't know if the arrow is indicating in the screen, but Bogota, which is in the middle of the country, has a population of 8 to 10 million inhabitants, and is the city with the highest number of cases. But not less important is the Caribbean coast, where the main cities are presenting a significant incidence. Also, our region, Cali, which is located in the state of Valle del Cauca, and close to Cali, in one of the provinces close to Cali, on the border of the Pacific coast, is Buenaventura. And this is presenting currently the highest incidence. As you could see, both the Atlantic and the Pacific coast are having a big burden of COVID cases. But also, as you could see down in the bottom of the map, there is Leticia. Leticia is a small town. This is in border, sharing the border with Peru and Brazil, and it is located on the Amazon River. Both the Caribbean and the Pacific, together with Leticia, are having among the highest incidences of COVID in the country. As you can see here, the incidence of Colombia as compared to Ecuador, Peru, and Brazil has been relatively controlled. And that has been because immediately after the appearance of the first few cases, with the quarantine we were subjected to, there was a quarantine for at least 2.5 months, and a strict quarantine. And only in the last, say, 3 to 4 weeks, the government has decided to start opening the economy again, and obviously the cases have started increasing. We didn't have the situation of a big spike, a big curve in the beginning of the epidemic here, but the cases have maintained relatively controlled during the progress of these 3 months. This is a situation, as you know, with this long border with Venezuela. We have about 1.8 to 2 million immigrants from Venezuela, we don't have good data from Venezuela, neither from the border with Venezuela, but we know that from the 1.8 million people during the pandemic, at least 100,000 people have tried to go back to Venezuela. And as far as the statistics are indicating, we have had about 700 to 800 cases reported as cases in Venezuelan people. We don't know exactly at this point if those are cases of Venezuelans that are already installed in a sort of definitive way in Colombia, or if they are immigrants that have been illegally in Colombia. In any case, the health system in Colombia is taking care of all cases, including any immigrant, independently of the legal status of the immigrants. So this is compared to the rest of the region. I think that we have been relatively protected because of the quarantine. However, obviously, after 3 months of close-down, I think that is, I mean, the economy is suffering a lot of violence, familiar violence has been evidenced, and the government decided to start reopening the economy little by little during the last 3 weeks. Obviously, cases started increasing. The incident currently is, as I mentioned already, about 109 per 100,000 cases. In the beginning, we had a big problem that I think that all countries in Latin America had experienced. It was the lack of preparedness to diagnose the cases, and after getting the training in the facilities, then the restriction in reagents and I mean other materials for the test. At this moment, Colombia has 76 laboratories, approximately 70% of them in the capitals, in the 5 main cities, what makes that there are many underserved regions of the country. Fortunately, those other regions are more or less rural, and then most of the cases are located in the big capital, as you would imagine. The capacity of Colombia is already good enough, I would say. We have the capacity to do approximately 18,000 tests per day. However, because of economic problems, and mainly because of the health system, which is significantly in the hands of private companies, are not demanding, are not requesting, and are not paying for the test. So we have made about 500,000 tests over the 3 months, but this corresponds to only 1/3 of the capacity, and maybe 20% of the ideal number of tests that you would like to have. This is, as I mentioned before, due to the limited access to reagents and equipment in the beginning. Now this is a problem that is relatively solved, but mainly because of the private health insurance companies are not ordering the tests for people that are developing symptoms, and again, besides that, there is a problem for the payment of those tests. Valle del Cauca, as you saw, the region where Cali is located, reacted immediately after the initiation of the pandemics in Colombia, and created what it is called here COPESA, which is a public-private health experts committee, where we established a number of subcommittees. The one was to ensure the hospital capacity for the region. Second, to create a group of experts in public health, epidemiology, and research. Third, another one to ensure the biosafety for the health personnel. Another one, grouping all the health and medicine schools from the region. There is a total of 12 schools of medicine united into an alliance that is providing training both to health personnel and to the community. And very importantly, a very large and robust group of psychologists and psychiatrists providing mental health. There is a very good effort in trying to maintain the mental health in the population, both those participating in the health attendance and the population as a whole. All these different subcommittees are very highly influenced or coordinated by the Secretary of Technologies of Information and Communication. We created a platform that is providing support to all the rest of the committees, and is especially covering the full region of the Pacific Coast. I think that this is an example in the country of a city, a main city that is providing support to 4 other regions in the Pacific Coast that I already mentioned, that there was a big incidence in Buenaventura and in Tumaco in the border with Ecuador. And this has been supported by this type of facility where you have access to, on real time, to the cases and the mobility of the cases and the contacts of the people. So we have been working together with this big alliance of where are participating the government, the NGOs, all the universities in the region, and lots of private and public volunteer people to attend the pandemics. It has had influence, a tremendous influence in the research and other type of projects in other diseases like dengue and malaria. And something that is very sad is that the mortality by dengue has increased in the last few months, as you could see here from this graph. It is representing in blue the incidence or the prevalence in March, April, May, and June of last year for dengue, because it's urban, is having much more increase in the last few months, and the mortality. And in the case of malaria, you would believe that this is going down, but this is a problem of under registration, because obviously because malaria is in rural and isolated areas, then we know that there are big peaks of morbidity and mortality in those regions, particularly in the Pacific Coast that I already mentioned, but they don't have access to diagnosis and they don't have access to treatment. So this is not only the problem of COVID here, but it's also influencing tremendously other diseases. I'm just giving the example what is happening in dengue and malaria, where one of our main projects that, as mentioned by Brownie, it has been basically stopped, arrested significantly because of the impossibility of going to these endemic regions and providing them diagnosis and service. I think that I will leave it there, and I will be happy to answer any questions around that.
Thank you, Socrates. Can you just stop sharing your screen, maybe? And so just a reminder, first of all, thank you so much to all of the speakers for sharing some perspective from your countries. It's already been illuminating. I want to remind the audience now to chime in with questions. I certainly have a few, but we'd love to hear from all of you. If you do submit a question, please let us know where you're tuning in from, whether it's a local institution in Boston or the Broad, obviously, or if you're joining us from maybe somewhere in Brazil or Colombia, please let us know. So I'll ask you a few questions while we wait for some to come in from the audience. First of all, I think I'd just love to hear from each of you what your personal role has been. None of you, I think, 6 months ago would have called yourself a COVID-19 expert, but I think in each of your own ways, you are becoming amongst the experts on the continent, and would just love to hear what you're doing in terms of clinical work, public health, public policy, and research work. Maybe we'll start with Fernando and just move through.
Thank you, Bruno. It's a hard question because finally our group is doing different things in this moment, and especially we have a part of the group in the lab working with the more basic science and also antiviral response, and especially we run a large network of clinical research in critical care, And especially in this case, we are running a large initiative together with colleagues of ISARIC, for example, collecting data from hospitalized patients in Brazil, but also clinical trials and more translational research. But also part of our group and family, the people that usually works with data science moved to look bear the data and try to have also bear data.
Great, thanks. And Marcia?
Yeah, so I am part of a large group of researchers based in Sao Paulo who are basically cracking data every single day and trying to support municipal and state health secretariats. Initially it was in Sao Paulo, but now it's many different ones all over Brazil. I have collaborations with the Ministry of Health in the surveillance department. And again, we're analyzing lots of data. And I have collaborations in the Northeast in looking particularly at COVID and pregnant women and children, child development. So that's a group that is not being studied a lot. We don't quite fully understand what are the impacts during pregnancy and for young children. So we are doing some work on that. With a former TACME fellow who is actually from Cruz, who works with Fernando in Rio, we are putting together a proposal to try to look at how immunity builds up, if it does, over time, and I hope we can move forward with that. And I've been doing a lot of public engagement because I think it's something we have to do. There's a lot of crazy information going around, so it takes a lot of time, but every opportunity I have in a serious venue to actually be able to talk about science and the truth, I take it. It's a lot of work, but I think it's something we all have to do at this time.
Excellent. And Socrates?
Yeah, well, okay. What happened here is that immediately after the initiation of the report of the first few cases in Colombia, as I mentioned, the governor organized this committee, and I was invited to coordinate that committee, and that brought me a significant amount of work. Not being an expert on virology and not being an expert as none of us is on COVID, but some of the things that I had done in the past, for example, being a professor at the university for more than 30 years, allow me to organize rapidly all the schools of health to start giving education to the health workers. And we established rapidly a diploma course. This is formal course. We have had a first cohort of 8,000 people already graduated from that, and a second round going on. And through that, inviting and trying to cover the Pacific Coast region, as I mentioned before, in terms of education. And education is something that is significantly important because it's covering from the very low level of education for people in the communities to training the intensivists and people experts in infectious diseases. Nobody was knowledgeable about that. And then I think that this is something that is doing very well. Second thing is doing this committee is ensuring the capacity of the hospitals to have enough intensive care units, to have enough biosafety material for the health people. The other thing we have been doing, obviously, is working very hard in trying to provide enough diagnostics. And among the group of epidemiologists and infectologists that we organize in this committee, I have been helping significantly in number of studies, research that has been organized in terms of epidemiology, public health, immunology. We are also doing a test on a study trying to understand the immune response in the different categories of clinical presentation of the disease. What happened with those? We are close to death in the intensive care units as compared to the significant number of asymptomatics. What is different among them? So this is a project that is going on. And basically this has been what was important here. I mean, I think the more important from the point of view of us as a research group is that because we were anyway forced to be in quarantine, then we decided to provide the facilities of the center and the human capacity of the institute to offer more diagnosis. So we have been working closely with the local government. They provide the materials and the reagents, and we provide the capacity, the human capacity and the equipment, and we are obviously strengthening the capacity of the government to provide more diagnosis. So in this moment, we are very, very much focused on the most underserved region of the Pacific coast of Colombia, because we, because of the social status of those communities, but also potentially because of ethnic reasons and genetics, there are significantly more COVID in the Afro-Colombian descendants and in the indigenous communities. So we are trying to provide support to those underserved regions.
Wow, great work, and certainly parallels, as I mentioned, to the work at the Broad to pivot our resources for testing in this region too. So thank you all for the important work you're doing. We're going to hand over to audience questions in just a moment. I just wanted to take the chance to touch on the issue. I mean, you've all spoken to it, but the issue of health disparities, racial and economic, and I think we can all see that, you know, in the U.S. and in the Boston area and in your countries, this is very much a disease of inequality, and would love to hear more from your perspectives of how that's playing out in Brazil and Colombia, and what has really been the response of the people, you know, in the U.S. driven by obviously many factors. There's just a lot of attention on racial health disparities at the moment, and we're hearing a lot kind of from the people asking for better. And is there similar factors and similar responses from the public playing out in Brazil and Colombia? How does that look?
So I can start. As I mentioned before, I mean, Brazil is marked by really heavy social and economic inequalities. And just to give one example, because we highlighted in the Amazon, it's about 43% of the population in the Amazon don't have access to water. So they cannot exercise the very first recommendation, wash your hands for 20 seconds with water and soap. So, but despite the inequalities, the way to go is then to have your responses that, you know, recognize those inequalities and target those inequalities, so then you can address them. Now, in the case of Brazil, the way to do this is to use the health system, is to use the community health agents. It's to use those folks that are right there in the community. They know where those problems are. And again, Brazil had time to prepare for this. So what did Brazil do? They just ignore the health system, they ignore the primary care, and they just say, okay, from starting tomorrow, everybody has to stay home. It's not going to work. So Brazil is this contrast of what it could have been and what it is. And it makes all of us, Brazilians or not, highly frustrated because the gap is so big, and we're basically measuring this gap in human lives. But so potentially we could have addressed those inequalities. They're there, they're huge. They are across municipalities, and you take any big city. And Fernando showed the map of Rio. I grew up in Rio, maybe he did as well. So it's highly unequal. So there's no way you can say, this is going to be the response and it's going to be the same across the city. It can't be. But we didn't have from the government that response. We had from the community. So you look at the slums in Rio, they have Organizations, they created their own websites to register cases and deaths. They have their own apps. They're basically being this, in the absence of the state, they're being the state. So you have all those governances going on to replace the absence of the state. It's been phenomenal. It's a mix of philanthropy, it's a mix of community leaders, and it's really beautiful. But the point is, as beautiful as this should be on top of a governmental response.
Mm-hmm.
And then it would be even prettier, right? But it can't be the sole response. Right. And that is the problem.
Fernando, anything to add? I'm sure you do.
Yeah, I agree completely with Marcia. And just to add that probably the best way was to really use the system, and especially the social engagement, with some lab capacity and to connect with new technologies, especially for active surveillance in the field, and also to connect that to social support, and also to mechanism of isolation that is really very complex to be done in some communities, but that not cost so much to organize that. Then, of course, the social action is an important piece of the disposal, but also, of course, also the coordination by the government is necessary. Mm-hmm. The society is very complex to organize in the middle of pandemic. For example, a testing program by yourself is almost impossible.
Mm-hmm. Right. Socrates from Colombia, what are you seeing? Oh, I don't think we can hear you.
Hello?
Oh, there you are. Yeah, thank you.
There you are. Okay. I think that the health system in Colombia is paradoxical somehow. I mean, we have gained in the last 2 decades a significant increase in coverage. I think that we are about 100% coverage with the health system. Almost everybody has access to health. However, what we can observe in this epidemic is that we have, I mean, a number, all the regions where we are having the highest incidences, regions where we have a very, very limited health capacity. And this is the Pacific Coast. This is Leticia in the border with in the Amazon region. This is Tumaco in the border with Ecuador. And then this instability in other countries is influencing significantly what can be observed in other regions. And also, as mentioned for Brazil, there is a big differences between the different regions. Mm-hmm. You could have, for example, places like Cali and Valle, the region where we are among the highest incidences, and regions like Medellin with the lowest ones in the country. And this is cultural. A few days ago, because of the holidays and so on, and the problems with family violence and so on, the mayor of Cali decided to comment that he was considering the possibility in the reopening of opening bars and discos and so on and so forth. Immediately people went to the street and started drinking and dancing, and obviously the incidence of cases went up. So the problem in Colombia at this moment, and what is going to happen in the next few weeks and months, is that because of the reopening, as the government has not the capacity to control the reopening. I mean, the government could theoretically think in reopening 10% of the activities, economical activities, but this 10% doesn't mean that 10% of the population is going to the street. Behind the 10% of the population that are released to go to the street, there are possibly 30, 40% more. So, and those people going to the street because the quarantine is being relaxed are those who are not under control. The people going to constructions and to the other sectors of the economy are under very strict control. But all the guys that are going behind, all the informal economy, all the people going to the traffic lights to sell cigarettes or candies and things like that, are extremely exposed. They are not following any rules. They are not social distancing. There is nothing. So we are, if we did it say, we had a good behavior and a good behavior of the curve in the beginning. Is not completely sure that we are going to continue that way, because we have now many more cases that expose to which the people non-immune are going to be exposed to.
Okay, thank you. So I'm going to hand over now to my my co-host Rafael, who's going to ask some questions on behalf of the audience. Thank you. Thanks for sending your questions, and over to you, Rafael.
Thank you, Bronwyn. So there is a question from the audience, specifically for Marcia from Qatarov. What forms of public engagement are the most effective to combat misinformation and fake news? And I would add, from a qualitative point of view, what has been the general reaction to the disease? Are populations in these countries skeptical, or are they taking the disease seriously and disease and public health recommendations seriously?
So let me start by the second question. It depends, because we still have people that support the president, and those people go to the streets and they gather, they don't use masks, and they, you know, are basically chanting horrible things, holding messages that the virus is not dangerous, whatever. I hope they're the minority. I don't know. I hope, period. I'll stop right there, but it's happening all over the country. Now, what is the most effective? Look, I think we have many different ways of trying to address this. I don't know what's the most effective, but at this point, we have to try them all and hope that at least some of them will have an impact. We have several people in Brazil now that there's one that is probably the most famous guy. He's a biologist, and he basically decided to take all the most complicated information from science and digest it in a way that anybody can understand. And he runs lives on YouTube, and like more than 1 million people watch that. Somehow this guy found me, and I did a live, and it was really popular. And then I've been doing a bunch of stuff only with serious people. Some of them I don't even reply, because when I check, I don't think that's gonna make any difference. So that's one. The other one is I've wrote op-eds, and I try to talk to media that has a lot of audience, because everybody reads that. You know, I get some crazy comments on Twitter, which I never reply, but that gives you an idea of what is the mentality of people out there. And I think it's important to know what's going on. So next time when you talk to, you know, a broad audience, and I think the attack is the best defense. So I address that immediately and try to respond. So I've been doing many different ones, and I don't know how is that working. One that I think is very important is I've done a lot of large lectures for universities, particularly in the North and Northeast. And those are the, you know, the folks that are entering college. And I think that's a good time to just throw the truth right at their faces. And I have absolutely no shame of, you know, speaking tough. So I've been doing that a lot, because I think that's important right from the beginning, so people understand how to differentiate the right and the wrong. Now, which of those are the most effective? I have no idea. I don't even know how we measure that, because the movement of fake news is really strong. It's growing, and this is everywhere. It's not just in Brazil, and it's not just with the pandemic, right? Elections are coming. Wait and see what's going to happen. So, but we got to try, and we got to try to find different ways of doing that. So that's what I'm doing. I'm trying, and hopefully some of this is going to work.
Thank you, Marcia. The next question is going to be, so we have Andres Foluri and Catherine Figueroa asked a similar question. I'm going to compile them both. What is the level of collaboration between countries in Latin America and COVID response? Is there any support being extended among countries?
I don't think a lot of countries want to work with Brazil. I'm sorry, but this is all about politics. Let me say one thing. Academic institutions, yes. I've never seen collaborations between researchers, academic institutions, and universities I'm seeing now. I mean, here in Boston, the best example is all hospitals are working together. This never happened before. So this is phenomenal. But at a governmental level, if that was the question, then we reach politics, and I don't think a lot of people are trying to. I mean, yeah, I don't know. Socrates, what do you think?
No, I think that the governments in the region are so busy with internal problems that I don't see. I hardly see how could they collaborate with other countries. I mean, they are. If I look at the Ministry of Health here, he is so much embarrassed, flying all the time, jumping from here to there, trying to solve the situation. That is hard to imagine that he could easily, interact with anybody. I mean, we see a government very committed, very the president, the ministers, everybody is very committed. I don't think that we have anything against the government for the internal situation, but I don't see how could Colombia help any neighbor in the current situation. Maybe it is, as you said, Marcia. I think that from the point of view of research, I mean, the academic is completely different. I think that we have things to offer and things to receive, and it's significantly easier to do it. But we are struggling here to get intensive care units for the country and trying to get diagnostics kits and things like that. I hardly see how could we help anybody else. We don't have even for us.
Just adding to from Zika outbreak, I think that now two new things I can identify. One is that is the support of companies and philanthropy to research that was not very common in Brazil. And the second is really the movement of data sharing that is expanding much more for clinical data or other kind of data. I think that this is also something that in some way the society and also the scientific community is engaged much more in this outbreak than before.
Wow, I think unfortunately we're at the top of the hour. And I think if there's possibly no better way to wrap this up than advocating for data sharing and information sharing. So yeah, we probably should have scheduled this for 2 or 3 hours, I think. But thank you all so much from me personally. It's just wonderful to have you as collaborators and partners in the work that we do. And on behalf of the Global Health Initiative and the Latinx community, just thank you for sharing your perspective with us. I think we have a long road ahead. I guess I'd be happy to have that as an excuse to bring the conversation back together again, maybe in a few months, and see where we are, and ask many of the questions we didn't get to today. So thank you. Thanks everyone for tuning in. We're continuing this series next week with a deep dive on health disparities related to COVID-19 in the Boston area, so closer to home next time. And we actually have a subsequent look at our Latin American communities with Mexico in, I think, early July. But more about that coming soon, so stay tuned. Thanks again to our panelists for sharing your time and experience with us. Have a great afternoon, everyone. Bye.
So bye-bye.
Thanks a lot, everybody.